Good evening, everybody. It is my pleasure to be here together with my good friend, Dr. Juan Crestanello, and we will talk about the tricuspid valve regurgitation, a topic that is of increasing interest to all of us. My name is Sorin Pislaro. I'm the chair of the Structural Heart Disease at Mayo Clinic, and Dr. Juan Crestanello, he needs no introduction, really. He's professor of surgery, and he's the chair of the Department of Cardiac Surgery at our institution. So without much further ado, we'll get into the discussion about where tricuspid regurgitation is in 2023. It is really, hopefully, at a turning point. We will cover very briefly the basics, and then I'm going to ask the question whether tricuspid regurgitation is bad for you. I hope that I'm going to share some of the new understanding related to tricuspid regurgitation, some tools for risk assessment, and then when it comes to fixing things, we always turn to our colleagues in surgery. So it's going to be Dr. Crestanello who's going to walk you through that particular topic, which is exceedingly important. So what are the basics of tricuspid valve regurgitation? For those of you who are practicing clinician, you know this is actually a very common condition. We think that about 1.6 million Americans have moderate severe tricuspid valve regurgitation. And despite that, only a tiny proportion of 0.5% or in that neighborhood undergo some sort of surgery or an intervention on the tricuspid valve, with an operative mortality that remains stubbornly high, unchanged over the last 30 years. And I know Juan is going to talk more about that particular topic. Really, it starts in the clinic. It is not that easy to diagnose. The symptoms are misleading. For the longest time, dyspnea on exertion was not part of the diagnosis in tricuspid regurgitation and was attributed to other type of heart disease, and we'll talk some more about that. Fatigue with activity, it's so non-specific, and then epigastric bloating postprandial or with walking, it's hard to gauge that in terms of symptoms. And when you look at the physical examination, many times it's silent. People usually do not have a significant murmur unless they have severe pulmonary hypertension. And really, how many people are really great at appreciating the right ventricular heave, the pulsatile jugular veins, or the pulsatile lever? So it's quite challenging. And because of that, really what happens is that tricuspid valve regurgitation diagnosis and evaluation depends strictly on high-quality imaging. And I think that's where echocardiography and more recently point-of-care ultrasound are going to make a great impact. So what are the basics of the valve? Essentially, we have several elements that all play out in terms of creating tricuspid valve regurgitation. So we have the right ventricle on the right side being at the Mayo Clinic, and we have leaflets themselves. We have a tensor apparatus, the chordae tendineae and the papillary muscle. Of course, the annulus where the leaflets insert, and right atrial and right ventricular myocardium. So any form of dysfunction at any of the level of the components of the tricuspid valve apparatus will lead to tricuspid valve regurgitation. In general, when we talk about tricuspid regurgitation, we talk about primary disease as being a disease of the valve, whether that be degenerative, rheumatic, valvulitis, carcinoid, or congenital. Or we talk about secondary tricuspid valve regurgitation, where the valve is actually intact, but we do have volume or pressure overload leading to dilatation of the right-sided chambers. We do have a right ventricular myocardial disease, such as in arrhythmogenic cardiomyopathy or right ventricular infarcts, or more recently, well described, the atriogenic tricuspid regurgitation in patients who have isolated atrial fibrillation. And really, when you think about tricuspid valve disease, you have to think that it's different than the mitral valve disease, meaning that most of the times, vast majority of the patient will have secondary tricuspid valve regurgitation, 90% of them, and only 10% of the patients will have primary disease on the right side. So is tricuspid regurgitation bad for you? We should know that by now because almost 20 years ago, Nat looked first time at what happens with patients who have tricuspid valve regurgitation. And what you can see on the left side, if you have progressively more tricuspid regurgitation, mild, moderate, severe, you have less and less survival. And that happens if you have pulmonary hypertension on the right side, just about the same, only to a higher degree. So again, impact of tricuspid valve regurgitation seems to be there. But at the same time, people keep discussing whether mortality is due to the comorbid conditions that lead to the tricuspid regurgitation in the first place, or whether that is related to tricuspid regurgitation itself. In other words, do people die with tricuspid regurgitation, or do people die of tricuspid regurgitation? And that is not simple to answer. Well, let's look at the forms of tricuspid regurgitation for which we do have an answer. So this is work for David Mesika-Zeytoun when he was a young fellow working here with Maurice Sarano and looking at patients who have isolated flayed leaflets of the tricuspid valve. And you compare their mortality versus the mortality in the population, in the general population, you can see clearly that tricuspid regurgitation per se will lead to excess mortality. So it is bad for you. How about in carcinoid? This is work from when Patty Pellica was just starting her career at Mayo Clinic back in 1993. She looked at patients who have carcinoid heart disease. You can see on the grayscale image the leaflets, the tricuspid valve leaflets are thickened and immobilized, and it's really massive tricuspid valve regurgitation on the color Doppler right next to it. And what we know from Patty's work back in 1993 is that if you do have cardiac involvement, you do have excess mortality in comparison with people who do not have it, and that is due to valvular heart disease, especially tricuspid disease. And that means, again, TR is bad for you. How about this paper by Jan Topilsky almost a decade ago? So Jan looked at patients who have nothing but idiopathic tricuspid regurgitation. What did he mean by that? Means you had to exclude everything that's left-sided heart disease in terms of valvular disease, coronary disease. There was no pulmonary hypertension, so nothing to be a trigger for the tricuspid regurgitation that was noted. And what Jan showed was that if you have severe regurgitation, that would be the curve in blue, with an effective regurgitation orifice greater than 0.4 centimeters square, you did have excess mortality compared to patients who had less than severe tricuspid valve regurgitation. So even if you have secondary TR in the idiopathic form, TR is bad for you. This is really an outstanding paper from our surgical colleagues. Sri Patlola worked with Hartzell Schaff, and they looked at patients who are newly diagnosed with atrial fibrillation. So essentially, they look at the Olmsted County population, and from those patients isolated, the ones who have new onset of atrial fibrillation had mild or less tricuspid regurgitation and no obvious structural heart disease. Exclude everything that you can exclude in terms of comorbidities. And then if you go forward in time and look at what happened with those patients, you see that actually about a third of the patients with atrial fibrillation of new onset do develop significant tricuspid regurgitation defined as moderate or more. We see some risk factors, but importantly, in the same study, what Sri was able to show was that as soon as you develop tricuspid valve regurgitation in that cohort, the risk of dying essentially triples. So the hazard ratio is substantially higher after you develop tricuspid regurgitation than before you develop tricuspid regurgitation. So that means that tricuspid regurgitation per se is associated with excess mortality, so it is bad for you. And despite all these data showing that tricuspid valve regurgitation is bad for you, if we look at a sample from the registry, how many operations are performed in the United States, it is really a small number per year. And despite this slowly growing number in time, it's still very low, and mortality is still quite high. And I know Juan is going to talk more about that. So why is that? I think mainly because TR morbidity is underappreciated, and therefore patients are under-referred for an intervention that would be potentially beneficial to them. So I think maybe it is time for us to have a new understanding of this valvular heart disease, and hence the interest at Mayo Clinic and many other institutions around the world to treat our patients better. So part of the new understanding comes in terms of symptoms. So I remember being a fellow, I was taught that right-sided heart disease and in general right-sided heart failure, the cardinal symptoms is fatigue. Patients are very tired, and it was felt that this is due to low cardiac output. And of course, you have edema, ascites, and abdominal fullness when you have severe tricuspid valve regurgitation. So if you see this patient who's 71-year-old has dyspnea, ascites, and edema, and you look at the tricuspid valve, you can see on the right side, again, the right ventricle is on the right side at Mayo, there's massive malcoaptation of the tricuspid valve. There's massive tricuspid regurgitation. And I can perfectly understand why this patient has ascites and edema, but why in the world is the patient dyspneic? So do they have that famed diastolic dysfunction that pretty much everybody else has? Yogesh Reddy, before he became a very talented young cardiologist and young staff at Mayo Clinic, worked with Barry Borlaug and with Rick Nishimura trying to establish what exactly happened with these patients. And Yogesh took this patient to exercise in the cath lab. So the patient is on the cath lab table. We are doing invasive hemodynamics. And as soon as the patient starts to exercise on the bicycle, on the supine bike, you can see at 20 watts, the right ventricle is enormously distended and essentially compresses the left ventricle. And in terms of pressure, what we noticed was that the left-sided pressures increase slower than the right-sided pressure, but nevertheless increase. And that translates into objective sensation of dyspnea. And sometimes people can go into pulmonary edema just because of that, mainly because you have that pericardial restraint that allows the pressure to transfer from the left side to the right side and from the right side to the left side of the heart. So they do not live independently. So don't forget dyspnea on exertion in patients who have TR. That may be an important symptoms for them. We know that TR severity is highly variable, and really, if you look with respiration, the effective regurgitant orifice nearly doubles, and regurgitant volume increased by about 40%, mainly because the gradient is a little lower in inspiration, but there is massive change with respiration. So we need to think what's the average tricuspid regurgitation. This is really an example of how bad tricuspid regurgitation can fool you. So we are in the cath lab before a biopsy. It's 11:12 in the morning, and you can see there's very little tricuspid valve regurgitation on the baseline images. And then what we have on the left side is a bioptome. Patients are getting in there, and what we have, as soon as you turn the collar on, you can see massive tricuspid valve regurgitation. So this is 7 minutes later. And you would say maybe we clipped a leaflet and we have now organic valve disease. But look what happens just 1 hour later, and 20 milligrams of furosemide given intravenously to the patient, the tricuspid regurgitation is completely gone. So within 7 minutes, we went from mild to severe, and within 1 hour from severe back to mild. So that means there's tremendous load-dependent variability in the tricuspid regurgitation, and we need to keep that in mind. There's really a 3D revolution in echocardiography, and we understand now that the tricuspid valve may not be tricuspid, maybe bicuspid as on the left, or maybe quadricuspid as on the right. And we can quantitate that, we can show that. We look more at the tricuspid valve annulus, that is highly dynamic structure. We can track it in time, and we understand now the physiology of the annulus. And what's important is to understand that during systole, the tricuspid annulus does contract. And that is a factor that is favorable for maintaining coaptation in the right side and preventing tricuspid regurgitation from happening. And Joan Nasser, who's one of our talented young fellows, looked at the concept of unfavorable dynamics in atrial fibrillation. Look at the patient on the top. This is a patient in sinus rhythm. And if you look here, this would be systole, 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 systole. You can see the minimal tricuspid valve area is always in systole, very, very systematic. Look what happened in this extreme form in atrial fibrillation, one of the patients. Every single cycle had the minimum tricuspid valve area in diastole. So during systole, the valve fails to protect itself from regurgitation. So maybe, just maybe, that is one of the mechanisms why patients do develop tricuspid regurgitation in atrial fibrillation. And finally, also in the 3D realm, we have to acknowledge the tremendous work done by the group in Italy with Luigi Badano and Denisa Muraro. 3D quantitation, 3D PISA, measurement of right ventricular side, right ventricular ejection fraction are all exceedingly important when you're going to make decision about what you're going to do with the tricuspid regurgitation. So that brings me to the last point in my part of the talk about risk assessment. So in general, when you talk about management, primary disease, we would think that an intervention will eventually be needed if the patient is symptomatic or they develop some sort of right ventricular dysfunction, and medical therapy will be really adjunct. In secondary disease, it's going to be much more like the secondary disease for the mitral regurgitation, whereby medical therapy is the first line, the most important. You treat the disease that caused TR in the first place. But then if you fail, I think there's plenty of room for intervention, and we'll talk more about that. So what should I do with this gentleman who came after having had valve surgery? He has severe tricuspid valve regurgitation on transesophageal echo. He has quite a hefty dose of furosemide already. So what should we do with them? And the key question for me in the office every single day is, what is the long-term risk of tricuspid regurgitation in the very individual patient I'm seeing right now, right in front of me? And you would say we are all clinicians and we have ways to gauge that. And you look at the patient, how they walk, how they do. But turns out that this is a complex issue. So these are patients, almost 13,000 patients were diagnosed with tricuspid valve regurgitation at Mayo Clinic, moderate or more. We only had up to 15 years follow-up, so we do not know later, but this is how long they live. And if you look at 76-year-old, our patient, you could see the patient may die within a month or may live to be 91 years old, another 15 years or so. And who exactly is the patient that I'm seeing today becomes challenging to me. And if you apply your knowledge, you say, well, maybe if you have hypertension, that's going to be a little worse. That's going to help me separate. But you see in red the ones who have, in black the ones who don't. It's still very, very variable. How about if you have diabetes? Just about the same. How about if you had history of heart failure? Just about the same. So individual factors are hard to put together. And because of that, we decided to look a little further how to define the risk with a simple clinical tool. And this is work that Kyla Lara-Breitinger, who is one of our new hires this year, who's a fantastic cardiologist, did in the last few years of her training. She looked at about 13,000 patients at Mayo Clinic, Rochester, and another 7,000 in Arizona and Scottsdale, trying to define their individual risk. And if you look at the role of TR severity, moderate, severe, you can appreciate that just like the NAT paper 20 years ago, we have progressively more mortality when we have more tricuspid valve regurgitation. But what we were able to do is isolate 8 very simple clinical factors: the age, the gender, the renal failure with creatinine level, the history of congestive heart failure, lung disease, an AST greater than 40 or heart rate that's tachycardic above 90, and presence of severe TR. And we give them 1 or 2 points and combine, they give us this TRIO, tricuspid regurgitation impact on outcome, TRIO score. And if you see here, there's a very distinct mortality if you have a low TRIO score at 0 or if you have a very high TRIO score at 9 or above. And Furthermore, we are trying to see how else does the TRIO score help us differentiate who's high risk and who's low risk. So again, this would be the low scores, it would be the intermediate scores, and this would be the high scores. So more and more mortality. But look at the low scores. If we break them down between moderate TR, moderate severe TR, and severe TR, there's a very distinct separation in the curve. So there's excess mortality associated with TR. The same if you go with the intermediate scores, but perhaps a little less robust separation. Whereas patients who are at high risk, we can see that there's almost no impact of the severity of tricuspid valve regurgitation on their mortality because they are already so ill with other comorbid conditions. So what we think is really that most of the patients in these two, low and intermediate risk scores, stand probably to benefit from an intervention on the tricuspid valve, whereas the patients in the lower right quadrant may have a symptomatic benefit, but probably we will not be able to impact their mortality as their disease is too advanced. So this is the risk score for our patient, and you can appreciate with an intermediate risk of 6, mortality at 1 year is still substantial. It's about 39%. So this is a calculator that we are almost ready to release online, and it's going to be eventually on the Mayo website for anybody to use freely. So what did I talk today before I hand it over to Juan? Really, tricuspid regurgitation is bad for you irrespective of mechanism. The clinical symptoms, don't forget to add dyspnea to the classic fatigue and edema. Dyspnea is an important symptom for patients who have TR. And for TR imaging, 3D and quantitation are key. The TRIO score, I think, is going to help the primary care physician understand exactly where the patient is in terms of risk stratification and refer them for potential advanced treatments or interventions. And with that, I'm going to hand over to Juan, who's going to take us to what you can do to fix diseases. Juan.
Thank you, Soren. So the most common etiology for tricuspid regurgitation is related to left-sided heart disease. It is either secondary to valvular heart disease or left ventricular dysfunction, and also pulmonary hypertension is a common etiology. Isolated TR is an increasingly recognized etiology for tricuspid regurgitation. An organic TR is not very common in the general population, but is very prevalent in our practice. And as Dr. Pisalaru mentioned, the impact of TR in survival is an adverse impact, and the severity of that impact increases with the severity of the tricuspid regurgitation. In general, tricuspid regurgitation, unfortunately, is referred late for treatment when the surgical risks increase and the benefit and effectiveness of the treatment on the patients decrease. Therefore, we advocate for an early referral for treatment before the development of right ventricular dysfunction or the development of organ dysfunctions like cirrhosis or end-stage or renal failure. As Soren mentioned, tricuspid valve surgery is not very commonly performed. Between 2000 and 2010, only 54,000 tricuspid valve surgeries were performed in the United States. The majority were concomitant tricuspid valve surgery associated with other procedures, and only 14% were isolated. The majority of the procedures were repair, and replacements were performed only in about 11% of the patients, and the majority of the patients received a bioprosthesis. And the operative mortality is high, it's 8.2%. And that remained high, and that's not the reflection of the procedure itself, it's the reflection of that patients are sick and are referred late for surgery. Most patients had advanced heart failure symptoms. They received surgery in a non-elective base. They had been recently hospitalized, or they have an organ dysfunction like chronic kidney disease or advanced liver disease. There's no Society of Thoracic Surgery risk model for isolated or concomitant tricuspid valve surgery. However, all the studies that had evaluated the predictors of mortality after surgery for tricuspid regurgitation signals that the severity of tricuspid regurgitation the age, the comorbidities, advanced heart failure class, the presence of right ventricular dysfunction or remodeling, and the presence of renal dysfunction and liver dysfunction are the key factors that predict the outcomes after tricuspid valve surgery. Now, a brief overview about tricuspid valve surgery itself. We can either repair or replace the valve. Let's go to the basics. So from the surgical standpoint, the tricuspid valve has three leaflets, an anterior leaflet, posterior leaflet, and the septal leaflet. And it's important to highlight the relationship between the septal leaflets and the AV node to avoid the AV node damage and blockage and require a pacemaker after the surgery. The other important concept is the dilatation of the annulus occurs mostly at the level of the anterior leaflet and the posterior portion of the annulus, where the septal annulus remains relatively constant. A partial annuloplasty band is the most common procedure that we use in our practice for repair of the valve, and that is consists the insertion of an annuloplasty band in the anterior and posterior portion of the annulus that decrease the size of the annulus, improving the coaptation of the leaflets. For those patients who have significant ventricular dilatation and significant tethering of the leaflets, placing an annuloplasty band alone will increase that tethering. And as such, we tend to perform a leaflet augmentation by putting a pericardial patch in the anterior leaflet to decrease the degree of tethering after annuloplasty, and as well as to improve the coaptation of the leaflets and decrease the rate of regurgitation recurrence. For those patients whose valves cannot be repaired, they should be replaced, and the replacement can be done either with a bioprosthesis or with a mechanical valve. In our practice, most patients receive a bioprosthesis, and the survival and the rate of reoperation either with mechanical or tissue valves is the same. However, mechanical valves are associated with a lower rate of TR recurrence over time. However, mechanical valves are associated with a higher rate of valve thrombosis and bleeding, and that's one of the reasons why it's not our preferred valve for tricuspid valve replacement. We only use mechanical valves selectively on those patients who are young and who have other mechanical valves in other cardiac positions. When we compare the outcomes of repair versus replacement, we can see that repair is associated with better outcomes in terms of survival for all patients, for patients who had functional TR, and for patients who had pacemaker-induced TR, as well as for patients who had a TR related to endocarditis. Both repair and replacement are associated with a similar rate of reoperation, and tricuspid valve repair is associated with a better preservation of the right ventricular function compared to replacement. The predictors of recurrence or the inability to repair a valve are similar and are related to annular dilatation, RV dilatation, the degree of leaflet tethering, and the degree of leaflet pathology. The first three talks about advanced and long-standing tricuspid regurgitation, suggesting that early referral for surgery will allow for more predictable repair, and also because repair is associated with better outcomes, as we just spoke, with a long-term improvement in the outcomes of patients with tricuspid regurgitation. What do I need to know when I see a patient with tricuspid regurgitation? Well, I'm interested in learning about the leaflet anatomy, the annular size, the right atrial size, the right ventricular size and function, the pulmonary artery pressures, and finally what the patient's rhythm is, whether the patient is in atrial fibrillation or not. And all these are important pieces of information that we obtain from the echocardiogram. This allows us to classify the patients on patients who have primary TR, where the defect is mostly at the level of the leaflets and there's minimal annular dilatation and RV remodeling. versus secondary TR, where the tricuspid regurgitation is either secondary to the pulmonary hypertension or to the left-sided heart disease, where the primary pathology is the RV remodeling and the leaflet tethering and the annular dilatation. And finally, isolated TR, where there is very little RV remodeling, there's no pulmonary hypertension, and there is massive dilatation of the right atrium that drives the annular dilatation and the tricuspid regurgitation. We're going to briefly touch in this time these different etiologies for TR and the surgical treatments and their outcomes. For primary tricuspid regurgitation, we're going to talk about endocarditis, carcinoid, and pacing leads. For secondary tricuspid regurgitation, TR associated with mitral valve disease, and finally, briefly talk about atrial fibrillation-induced TR. Endocarditis. This is a patient who unfortunately had a history of IV drug abuse, present with fevers and chills, and this is the echocardiogram. She had a severe tricuspid regurgitation. She was treated with antibiotics and then taken to the OR, and this is what we found. And in the panel on the left, we can see the vegetation on the anterior leaflet of the tricuspid valve. We resected that vegetation, and then we placed together the edges of the anterior leaflet, and then we place an annuloplasty band. And then we can see here the results where there is minimal residual tricuspid regurgitation and a 3 millimeter gradient across the tricuspid valve. For those patients who had massive destruction of the leaflets, tricuspid valve repair cannot be performed, and in those patients, a replacement is necessary. And we recommend, particularly in patients with endocarditis and especially in patients who had a history of drug abuse, to use bioprosthesis rather than mechanical valves. The patterns of tricuspid valve surgery in patients who use drugs versus those who don't use drugs is different. In patients who use drugs, tricuspid valve surgery consists on 40% of all the surgeries for endocarditis, where on patients who don't use drugs, it's only 10% of the surgery for endocarditis. In patients who don't use drugs, the majority of the valve can be repaired, while in patients who use drugs, the majority of the valve needs to be replaced. And that speaks about the degree of destruction associated with the organisms present in patients who use drugs. Carcinoid heart disease. About 25 to 50% of the patients with carcinoid syndrome present with carcinoid heart disease. It is related to the bathing of the valve by serotonin that leads to fibrosis of the tricuspid and the pulmonary valve. The tricuspid valve is involved in almost all cases, and this is the typical appearance of the valve, which is whitish discoloration with thickening leaflet, fibrotic and retracted, as well as retraction of the subvalvular apparatus and the presence of the carcinoid plaques in the walls of the right atrium. This is an echocardiogram where we can see the tricuspid valve, which is thickened with decreased mobility and with retracted and very severe tricuspid regurgitation. In our clinics, as of now, we have operated almost 300 patients with carcinoid heart disease. As we said before, the tricuspid valve and the pulmonary valves are involved in almost all patients. The left-sided heart valves are rarely involved. We usually use bioprosthesis on these patients, since the carcinoid involvement of the bioprosthesis or recurrence of the carcinoid disease on the bioprosthesis is very rare. The operative mortality is low and has continued to improve over the course of the years, and the long-term survival is better with surgery than with medical management. And the patients who undergo surgery, they're normally die from progression of their malignancy rather than dying from congestive heart failure. Pacing leads. There's two different, clearly different etiologies related to the pacing leads. One is lead associated, where the lead is a bystander and the tricuspid regurgitation is related to the heart disease due to either pulmonary hypertension or mitral valve disease or other left heart disease pathology. And the other etiology is lead-induced tricuspid regurgitation, where the lead is what is causing the tricuspid regurgitation. And these are the mechanisms, are either restricted leaflet mobility by the lead, scarring and fusion of the leaflets, chordal entrapment, and finally perforation of the leaflet. And I'm going to show some of the examples. This is a patient who had a pacemaker, and we can see how the septal leaflet mobility is compromised by the lead. We took that patient to the operating room, and we performed a similar repair of what we see in this diagram, where we exteriorized the lead in the commissure between the anterior and the posterior leaflet, and then we place an annuloplasty band. The overall concept here is to remove the lead from the coaptation zone of the leaflet. And this is the postoperative echocardiogram, where we can see that there is a minimal or no residual tricuspid regurgitation. This is another type of situation, is the chordal entrapment. The patient as well has severe tricuspid regurgitation, and when we took the patient to the operating room, we can see the lead had produced a scarring of the subvalvular apparatus, and in this, as well as the leaflet itself, and in this situation, it's very difficult to repair the valve, and the valve needed to be replaced. And when we replace the valve, we leave the leads outside the sewing ring of the valve, in between the sewing ring of the valve and the annulus of the tricuspid valve. And this is an important concept that needs to be emphasized, because doing this, it allows the lead to be removed later on if it is necessary. Another thing that sometimes do, and that's important, particularly important if we are using mechanical valves, it is to remove the leads and place epicardial leads that can be connected to a pacemaker if the patient is pacer dependent, or it can be left a tunnel in the subclavicular region for later use if the patient becomes pacer dependent. Finally, it's not only the leads are not only important on patients who actually have a permanent pacemaker right now, but it's also important on patients who had a pacemaker in the past. This patient had an ICD for 3 years, 10 years before of this X-ray, and presented with symptoms of congestive heart failure and torrential TR. And when we took her to the operating room, the whole posterior leaflet of the tricuspid valve was missing. Mitral valve disease is the most common etiology for tricuspid regurgitation. What to do with TR at the time of mitral valve surgery? Well, when patients had moderate or severe TR, we recommend repair or replacement. In general, when patients who had trivial or mild TR, we recommend to do nothing. And it's controversial what to do with patients who had an tricuspid valve annulus, which is dilated, and the dilatation is when the annulus is greater than 40 millimeters. What do we do in our clinic? Dr. Schaaf has reviewed more than 1,600 patients with mitral valve surgery for degenerative MR. About a third of those patients had tricuspid regurgitation that was moderate or severe, but only 15% of those patients, half of those patients who had moderate or severe tricuspid regurgitation, had concomitant tricuspid valve surgery. And the likelihood of tricuspid valve surgery increases with the severity of the tricuspid regurgitation. So this is a patient who had myxomatous mitral valve disease and severe tricuspid regurgitation. We repair the valve at the time of the mitral valve surgery with placing an annuloplasty band. And here we can see the probability of TR on long-term echocardiographic follow-up up to 10 years on patients who had no concomitant tricuspid valve surgery or no tricuspid valve surgery at the time of mitral valve surgery. And we can see that the performance of concomitant tricuspid valve surgery is associated with a lower probability of moderate or severe TR at follow-up. In terms of the survival, the unadjusted survival is obviously better for those patients who have had no tricuspid valve surgery. But when we adjust for the baseline characteristics, the overall survival is the same of those patients who had tricuspid valve surgery versus those who had no tricuspid valve surgery. And this has also been shown in the CTSN trial that we will discuss in a few moments, where a tricuspid valve surgery decreases TR but does not improve survival. So what to do with an annulus that is dilated? The guidelines recommend for those patients who have a dilated annulus to perform a concomitant mitral annuloplasty at the time of mitral valve surgery. However, our experience reviewing more than almost 1,200 patients with preoperative TR, moderate or less at the time of mitral valve surgery and no tricuspid valve procedure, shows that tricuspid regurgitation progression was not influenced by annular diameter, either when that was evaluated as a continuous variable or when it was evaluated as a categoric variable in diameter greater or smaller than 4 centimeters. In the CTSN trial, patients with moderate TR or less at the time of mitral valve surgery were treated either with mitral valve surgery alone or mitral valve surgery plus tricuspid annuloplasty. And the addition of tricuspid annuloplasty decreased the progression of TR from 6.1% to 0.6% at 2 years. But these results need to be analyzed in the context of the two different types of populations who were enrolled in this trial. 60% of the patients enrolled in this trial, they had less than moderate TR at baseline, and they were just enrolled based on the fact that they had annular dilatation. And in those patients, there was no TR progression, either with or without a tricuspid valve annuloplasty. However, in those patients who had moderate TR at baseline, tricuspid annuloplasty, concomitant tricuspid annuloplasty decreased the progression of TR from 14% to 0. That didn't have a cost in terms of operative mortality. However, in terms of morbidity, it was associated with a 14% rate of a permanent pacemaker. In our experience, the rate of permanent pacemaker is 3%. So I think that we have to go beyond annular diameter alone and consider other factors like the presence of atrial fibrillation, the severity of the pulmonary hypertension, the function of the RV, the size of the RV, the degree of leaflet coaptations, and and the size of the annulus in terms of very large annulus to really decide what are the patients who benefit from concomitant annuloplasty when the annulus is greater than 40 millimeters and there is less than moderate or less tricuspid regurgitation. So further investigation is necessary in order to clarify this point. In terms of atrial fibrillation, those patients who had tricuspid regurgitation induced by atrial fibrillation had very massive, very dilated right atriums with very dilated annulus. With a normal right ventricle, and in general, they don't have pulmonary hypertension. And in those patients, annuloplasty and a concomitant MACE procedure should improve the outlook. Finally, the tricuspid valve interventions through transcatheter procedures. There's a lot of interest and there's a lot of investment on these devices, and they are coming, and there's going to be a very fruitful intervention for our patients in the future. Most of these devices are under clinical investigation at this point. There are devices for valve replacement. There are devices for leaflet repair. There are devices for performing annuloplasty. And we're going to briefly touch on leaflet repair. Currently, the Pascal device, which is a clip device that independently allows to clip 2 leaflets of the tricuspid valve, is being used. This is an animation that that shows how the device is applied, and it's associated with good outcomes. It decreases TR in the majority of the patients, and it also is associated with improving functional class as well as quality of life at 1 year. Finally, a tricuspid valve replacement with a transcatheter device is also ongoing. There are several devices. This is one of them. This is the Evoke device, which is a self-expanding valve that has these arms or legs that traps the leaflets and stabilize the valve in the annulus. And it also has been very effective in abolishing tricuspid regurgitation. So, in summary, tricuspid valve regurgitation is common. It has an adverse impact in outcomes. It's undertreated. It's usually treated late. And the impact of the treatment in outcomes is not very well defined. However, we believe that early treatment that possibilitates the repair of the valve should be associated with improved outcomes in terms of functional outcomes as well as long-term survival for the patients. But nonetheless, I think that tricuspid valve regurgitation provides a great opportunity for cardiologists and surgeons to work together to define the natural history of the disease as well as to define the optimal time for the treatment, the type of treatment, and the outcomes. Thank you very much.
So Juan, this was a fantastic whirlwind tour into how to fix the tricuspid regurgitation at surgery. And of course, we have all the transcatheter procedure coming up. I'm going to remind the audience that, number one, this will be posted in about 1 week on our website. So if you didn't have the chance to watch it live, you can always go back and watch it. It's going to take us about 7 days to get all the upload done. And I would also encourage everybody to submit your question online. So we are live, so we can have a question and answer session. And you know, when you have a surgeon, you always ask the surgeon what they think and what they do. So it's a good opportunity to squeeze all the information from my good friend Juan Crestanello. So I'll start with that. What is too sick for surgery, Juan? So you had the 3 very patients. So Juan has this story about the 3 very. So maybe you can share with us.
So, well, the story of the 3 varies is that when there's always a cardiologist who, or one of your colleagues, and sometimes it's you, who wants to send a patient who is really sick for surgery, and they always call you and they say, well, we have a very nice patient with a very nice family who was very active. And the problem is that they don't tell you when he was very active. It could be 10 years ago. But nonetheless, I think that judging how sick the patient is, it requires a lot of judgment, but also it requires a lot of objective data. And the objective data is based on what the age of the patient is, what the expected survival is, what the comorbidities are, and we normally use different scores. I mean, in terms of trying to gauge what the overall survival of the patient is with or without surgery, we use the TRIO score, and that we have been using that increasingly in terms of determine whether there's going to be that group of patients with significant organ dysfunctions who's going to die with TR, regardless of what we do, versus those who are dying from tricuspid regurgitation, and we will help them by doing the surgery. They use other scores like the MEL score or the child puke score that tell us the degree of liver dysfunction is also important. Evaluating the severity of the renal dysfunction, the functional status of the patient, where they're able to recover from the physiological impact of the surgery, the degree of thrombocytopenia, the degree of abnormalities in the liver function, the degree of pulmonary, the portal hypertension are also important concepts to evaluate on the patient. And at the end of the day, we use this common group of parameters from objective parameters to subjective parameters, and we make a decision. But it's not, the decisions are not always perfect.
So we have some questions for the audience, so we can take them one by one. So if diuretic affects TR significantly, when you will reliably measure the regurgitation? So maybe I'll take this one. Depends on the setting, but you need to push the diuretic to the max. There's not a lot of medication that you can do for right ventricular enlargement and RV dysfunction and RV failure other than diuretics. So there's a number of things we try. But if you're in the hospital, we have our colleagues in heart failure, sometimes they push 20, 30, 40 pounds volume loss in a week or 10 days or whatnot. And then what we do when we think we're back to the dry weight of the patient, that's when we reassess the severity of TR. If you're in the outpatient, obviously this is going to happen slower in time. But I would encourage everybody, when you start somebody on diuretic, see if the diuretics work. If the low-dose diuretic didn't change the TR, maybe go a little higher, keep escalating. And once you hit a steady dose and you think this is as far as you can push it because patient becomes pre-renal, they start getting lightheaded and what have you. Once you hit that, you're not going to get any further than that. So to me, that would be the time when you regroup and you say the TR is severe and permanent with us, or no, it's a chance that we may be treating it with medication alone. Then what's organic disease? For us, organic disease is primary disease of the valve. So carcinoid, rheumatic, anything like that. What is the role of stress echo in evaluating severity of TR? So Juan, is it important to you to get that or not? What do you think?
Well, it's another piece of information that also help us to make a decision. I mean, I think that you can expand into that.
So our colleague Sari Padang has a vested interest in stress in valvular heart disease. So we look more and more, just what Juan was mentioning. We want to have a number. How fit is the patient? How far do they go? So that's one piece of the information. But the other piece of the information is in patients who have unexplained dyspnea, sometimes when we stress them, we see that they actually do develop severe valvular heart disease, whether that be tricuspid or mitral. So when you have a patient in whom you tested everything else and nothing really pops up to explain their dyspnea, maybe that's a good idea and you'll be surprised. On occasion, we've seen that. Which surgical score for the right side, Juan? Which would you use for the there's no STS score, so
well, there's no STS score. There's a TRI score, which is another score that has been developed by Dr. Dreyfus in France, that use a combination of echocardiographic, clinical, and laboratory parameters in order to predict the 30-day mortality after surgery, and that has been very accurate. However, it has developed based on a small group of patients, only 400 patients with isolated tricuspid valve surgery. So, and it really needs to be validated in larger populations in order to determine how predictive it is. But there's really not a single number that we use in order to determine whether a patient is candidate for surgery or not.
I mean, to me, this last year brought two scores. So I promise you, we never knew of them doing that, and probably they didn't know about us doing that. So we named our score almost the same. Our trio score, there's tri score, but I think they're slightly different. One is for the primary population, one is for patients you consider for surgery. And finally, we have some tools to measure how sick the patients are and try to understand how advanced is their disease and leverage that information in our decision. So it's important. Now, a question is, will restoring normal sinus rhythm in a patient with AFib reduce the severity of TR? Do you want to take it, Juan?
Yes, we have seen that.
Yeah, so we do not have systematic data to look at, but multiple times we have seen that if you're aggressive in treating patients who have new atrial fibrillation, that TR may go back. And if you remember that study where Hartzell-Schaff and Sri Patrola look at who are those patients with AFib who develop TR in the future, one of the risk factors for developing atrial fibrillation was a rate control strategy. So in other words, if you don't give a shot at least to putting the patient in sinus rhythm, you may miss the opportunity to treat their TR because the annulus may remodel in a favorable way.
Yeah, there's another study from the clinic, which is already probably 10 years old or probably older, where patients who had atrial fibrillation and mitral valve disease had either concomitant MACE procedure or not, and those who had restorative sinus rhythm had less progression of TR over the course of the follow-up up to 5 years.
So question about pacemakers. So it seems you touched the chord with that, Juan. So have you been removing RV leads and replacing with leadless RV pacer before the intervention on the tricuspid valve? And have you seen worsening RV dysfunction post TTVR?
Well, in terms of the replacement of a leadless pacemaker. Normally, if there's a patient who requires a pacemaker after tricuspid valve repair, we try to discuss with our EP colleagues the use of a leadless pacemaker, because I think that will have a significant benefit in order to prevent the recurrence of tricuspid regurgitation over time. The other strategy is that there is any conduction abnormalities at the time of the tricuspid valve repair, epicardial system should be placed. In terms of the degree of RV dysfunction with patients who had a tricuspid valve replacement, either with surgical prosthesis or with a percutaneous prosthesis, is similar. I mean, and that just both lead to significant degrees of RV dysfunction. And that's because of the change in the afterload mismatch that occurs after making the valve competent.
But many times that recovers in long term, right?
Yeah, it turns to improve over time, and then in the long term there's a progressive deterioration.
Yeah. And we've seen that also. It's not only for surgery. We've seen that with the transcatheter valve. So we'll see when the study is published and all data is analyzed. But anecdotally, we have seen that the right ventricle looks a little worse the next day, at least on occasion. So this is a loaded question, an important question. Can LV failure meds work in RV failure with tricuspid valve that is secondary to... so in other words, can you use left-sided medication for the right-sided medication? You want me to take this, or do you want to take it? So we'll ask then Juan what to do when we fail the medication. So this is a very important question. If you look at the same study of the isolated TR in patients with atrial fibrillation, and if you go forward in time in those patients who develop AFib, only a fraction of them are truly isolated tricuspid regurgitation. Only about a third remain truly atriogenic, whereby about half of them have manifest left ventricular sided disease. Is that because they had LV disease that progressed in time and now you pick it up? Some people had pulmonary hypertension develop. Is that because they had it and now it's getting worse, so you pick it up? It's quite possible. But I think in my practice, if I suspect heart failure or preserved ejection fraction, I would have no problem using SGLT2 inhibitors for the left-sided heart failure in the hope that maybe the tricuspid valve regurgitation would get better. And actually, one of the clinical trials ongoing for transcatheter valve replacement has a requirement that the patient is maximally treated, including with SGLT2 inhibitors, for potential left-sided heart disease being the cause of their secondary tricuspid regurgitation. So Juan, after how long should we treat the patient before we say, gosh, we gave medical therapy a chance. We keep going. The patient is relatively stable. The RV begins slowly to enlarge. Function is harder to gauge. When would you want the cardiologist to say, maybe it's time to talk with our surgeon friends, the very, very, very.
Well, I think that the two points I want to make. I think that defining a population who has isolated TR alone with no other heart disease is, as you say, is very difficult, because the atrial fibrillation that is driving the TR, it also drives probably MRs or some degree of MR, and probably also some degree of LV dysfunction. Therefore, isolating a disease and putting a disease exactly in a box is very difficult to do in the individual patient. It's very conceptually is very easy to do in a manuscript or in a paper, but really to identify a single factor that is driving the disease in one patient, in particular in such a complex disease as atrial fibrillation is very difficult. In terms of the optimization of the patients before surgery and the referral to the patients for surgery, the early the better. And I think that we do not know the optimal timing for repair of the tricuspid valve, and we don't have the robustness of the studies that are in the mitral valve arena in the tricuspid valve. But if we operate on the patients with tricuspid regurgitation before the development of right ventricular dysfunction or congestive heart failure symptoms or end organ dysfunction, it should lead to better outcomes. And that's the theory, but we haven't been able to demonstrate that yet. And I think that the further studies of cardiologists, surgeons, interventional cardiologists working together is up to us over the next 5 to 10 years to define that work that Mauricio Serrano did 20 years ago for the mitral valve disease, to translate it into the tricuspid valve and prove that that's the case.
I think this is a very good message to wrap up and finish our webinar on tricuspid regurgitation. Juan, I completely agree with you. There's so much that we don't know yet, but the key message maybe for us and for our audience is, do not ignore this disease. This is a disease that has real implication, and it's always better to just get your colleague, your friend, the cardiologist, if you're not, if you're internal medicine or your surgeon or your interventionist. Try to talk about things. It doesn't mean we are going to necessarily do an intervention, but for sure we'll think about it. For sure we'll do the medical therapy, and our collective knowledge hopefully will push this a little forward with better outcomes for our patients. So again, I want to remind everybody, in about a week we will have this online, and then I'm going to tweet about that. It's going to be my second tweet of the day. So hopefully we will have something to be linked in the near future. I want to thank Juan for taking the time. He's a very busy surgeon, so it was great that we could take 1 hour of his time. I want to thank all of you for being there and listen to us. Our emails are available, so if you have questions that we didn't answer, send them in. We will try to address them one by one. And if you ever have questions about patients and care and anything, let us know. We'll be happy to assist you with whichever way we can do that. So thank you, everybody. I'll say have a nice evening, and Juan, you have the last word.
Thank you very much. Thank you, Soren.
Thank you.